so good afternoon. We're going to go ahead and get started. And on behalf of Lurie Children's Pediatric Research Evidence Synthesis Center of Innovation and Implementation that was begun by Dr. Renee Mann-Warren of Lurie Children's, we are very happy to introduce and have you attend this webinar, whose focus is on health literacy and evidence-based methods to address this important topic. And before we introduce and have our esteemed speakers provide our presentation, I do have a greeting that was sent to us by Adelaide. That is the JBI Center that is centered in Australia. So without further ado, I'm going to bring up that welcome. So please be patient as I bring that up, and then we'll go right into our panelist presentations and then go into any questions or panel discussion that occurs after our two presentations. So thank you. And on behalf of Dr. Renee Mann-Warren and the Precise chapter of Lurie Children's, we welcome you.
Hello and welcome to the JBI gLocal Solution Room. This is an event that's really designed to engage clinicians in getting evidence into practice. For those of you who perhaps aren't familiar with JBI, we really are all about getting evidence into practice, so using the best evidence to get good outcomes and create a brighter future. Now in recent years, I've been thinking a little bit about this idea of a flywheel effect. And the original concept came from a guy called Jim Collins. And what Jim talks about is the fact that organisational change never really happens in one fell swoop. There's no magic bullet, there's no solitary lucky break. It's about having consistent attention to something to drive change and to make organisational change happen. And I really felt like this has got some useful synergy with evidence-based healthcare and the forces that drive the successful translation of evidence into practice. Hopefully, most of you are familiar with the JBI model, and we've recently published a paper about the idea of an evidence-based healthcare flywheel. And what we did when we redeveloped the model in 2019 was to add these, we call them overarching principles, but they're underneath, so they're kind of foundational principles around culture, communication, collaboration and capacity. And really we see these as the catalytic mechanisms that are required to successfully drive forward evidence-based healthcare initiatives in organisations. Now we certainly recognise that evidence-based healthcare is relational. It's not transactional. And if we want to empower people to change their behaviour, then we really need to give some careful, thoughtful and consistent attention to navigating the relational matrices that organisations are run by. Now we don't want to reinvent the wheel, we just want to get it moving. And so, as you can see by this graphic, we really feel like those 4 C's that we added several years ago to the model are the drivers of the momentum required to get evidence into practice. And I think that's a really important focus area that we probably haven't paid sufficient attention to. We don't talk about them very much, we don't articulate them, but we know that they are the things that require attention in order to see change happen successfully. So I'm really excited that this week we have 35 gLocal events happening. And you have to remember that this is an event that started as the local solution room here in Adelaide a few years ago, and really it was just an effort on our part to re-engage with stakeholders across South Australia. But when we shared the concept with our international collaboration, they were really excited by it. And so over the years, we've seen the number of events grow, and now we have an extraordinary number of events happening, which is just so exciting for us to see. We know that change can happen with just one pedal, with just one person And so we're excited to see the ripple effect of change that came out of that one event, and we're excited to see the ripples that will now flow across the world. I hope that whatever event you're participating in this week, that you have a really enjoyable time, and I look forward to hearing more about them. Thank you.
So with that being said, I would like to invite our first speaker up here for the evidence-based practice incorporating health literacy into practice. I'm going to have this speaker introduce her credentials. It was sent out as a handout. I will not be able to do her justice. She has a wealth of experience as a nurse anesthetist in current practice, but also a member of the College of Nursing at Rush University. So please come up and just give a brief introduction to your background, and we'll look forward to your presentation. Thank you.
Hello everyone, my name is Maiko Yamashita. I am a practicing CRNA. I actually have a slide with a tidbit about myself, so maybe I'll save the details for that slide. But in summary, yes, I am a practicing CRNA at Rush University. I am a program director of Rush University's nurse anesthesia program. And today I'm very happy to be here to present about health literacy and the health outcomes related to this. And I'd like to thank Lurie Children's Hospital for hosting. I have no financial disclosure or conflicts of interest to share at this time. These are my objectives, which are to understand what health literacy means, grasp the various impacts of low health literacy, gain knowledge on the prevalence and statistics related to this. And this is actually an interesting part, which is the definition of health literacy. And it's defined by healthy people, and I'll guide you through the changes that have happened across the decades. And then lastly, and most importantly, how you can envision yourself and your organization in changing our practice to be evidence-based and keeping in mind health literacy as we take care of our patients. This is my son here. Okay, so here's a bit about me. I am a mother of two. I live in the city. I'm a practicing CRNA at Rush University Medical Center. I am a program director. I'm the oldest child of an immigrant family, so I don't know if we have any immigrant family children out there, but you are the designated interpreter for all. So it can be the bill collector, the grocery store, the doctor's office. So really, I guess that would be my second to first experience with health literacy was awkwardly interpreting at the doctor's office when you're 9, for example. But before then, my first exposure to the impact of health literacy was when I had surgery at the age of 4. So even at this point, I can't tell you what surgery I had. I know it was somewhere in my neck. I'm very thankful that they did an excellent closure. There's no scar. But my parents signed a consent form, and to this day, they don't know what they signed for. They just knew that the doctor said this needs to be done, so they signed it. And that's an example of how health literacy can impact a patient. So health literacy. This was designed, I made it cyclical because you can see that everything is really interrelated. So it is a public health crisis and a global crisis. And the 4 elements to it would be prevention, management, protection, and cost. For prevention, there are many different elements to this, and again, they are very interconnected. So for prevention, there's reduced access to accurate healthcare information. The term accurate is what I'll highlight here because right now we live in a society where it's almost overload in the terms of the accessibility, but the accuracy then comes into play. We've all seen something on Facebook or Instagram where we're like, this can't be true. You know, there's so much information out there. So it can be challenging for people to discern what's accurate and not. But when there's a lack of access to accurate information, this can lead to delayed access to preventative screening, routine care, mammograms, etc. So with the delaying of care, there's the delaying of diagnosis that's made and treatment. And that can lead to poor outcomes and then also lead to increased comorbidities. And then lastly, there's impacts of other disparities such as income, education, access to health care, and food. So an example of how this is all interrelated, Northwestern produced a really interesting mapping of food deserts in the city of Chicago, and they're very much correlated with socioeconomic income. So with food deserts, there's a decreased access to fresh fruits and vegetables, which then increases the intake of sodium and sugar. This has led to an increase in the diagnosis of hypertension and diabetes. But if there's no access to information on healthy eating and exercise, decreased access to food, and then you're delaying care by seeing a provider, it leads patients and community members to have hypertension and diabetes that are undiagnosed, and it becomes more of a complex situation where you can end up with an MI, stroke, and death. So all these things are very much interrelated. Next is management. So as your health literacy and the number of comorbidities you have is very much correlated. So the lower the health literacy, the higher the number of multiple diagnoses our patients have. So when you think about this, you have the intertwining of systems, not just organ systems, but also your patients are utilizing multiple different specialties and healthcare across your organization. So for example, a patient may have asthma as well as congestive heart failure. Those are two different issues, but sometimes they can present in a similar way when they have exacerbations such as shortness of breath. So what is the primary issue here? It's really challenging for our community members to identify this. They're also navigating through your hospital system. They may see their cardiologist over here, they're seeing their pulmonologist over here, etc. So it really becomes complex for our patients. It's also a situation where there's longitudinal care. It's not a cause and effect, one and done situation for our patients. They have long-term treatment plans and really ups and downs in terms of their management. And then there's an increased need for numeracy. Numeracy is the ability to utilize numbers in the form of ratios, percentages, etc., to be able to make an informed decision for themselves. And health literacy can impact this greatly. So an example of this would be a study that was done by Lopez Perez that identified 279 men over the age of 50 with various health literacy levels, all diagnosed with the same diagnosis, which was localized prostate cancer. They were provided the same education tool, which gave them two options for treatment. One was active surveillance, the other was a radical prostatectomy. With these, they were given the pros and cons of both, and they were given numbers, so numeracy, to make their decision of what plan they would like. So with the active surveillance, although they would have no side effects from treatment, they have the risk of their cancer becoming metastasized later on. But because it's localized, they were given the risk that it is a low risk. The second part is the radical prostatectomy. Although your risk of malignancy would be decreased significantly, you do have the risk of immediate erectile dysfunction and urinary incontinence. So what they did was they studied what treatment plan each patient chose, and patients with higher health literacy chose active surveillance, while patients with low health literacy chose radical prostatectomy. So it shows that numeracy does play a role in how patients are making decisions for their health care, and it is definitely impacted by health literacy. Next, we have missteps. So I have a person juggling balls here, and it's very much so. We've all seen patients with the long list of diagnoses, medications. I don't envy their juggling at all, because it's really challenging. And many patients really genuinely try their best to manage all their issues, but it's challenging. And when you have so many medications and diagnoses that you're managing, it leads to the increased risk of misunderstandings from your provider or errors in your medication. Sometimes you may get conflicting information. I know Audrey and I see this where the cardiologist will say, continue your anticoagulants, and the surgeon will say, stop it 5 days before. So the patient's like, I'm not really sure what to do. So it leads to conflicting information at times. And then last, different impacts would be increased ER visits, which I'll touch on during the cost portion, increased admissions, progression of disease, and increased morbidity and mortality. Many times this increased admissions could be the exacerbation of symptoms. It could be medication errors. For surgery, it can be post-surgical complications because the patient did not understand the discharge instructions. This is very relevant now. In the United States, a little over 60% of procedures are done outpatient, meaning patients are getting their discharge instructions after they recover, and they're sent home, and they're managing their care by themselves or with their support team, and they're really relying on that information provided to them. Next is protection. So through health literacy, it's important to remember that accessibility, readability, and utilization of accurate health information is important. This can lead to protection from harm, protection from disease, and protection of rights. So an example of protection of harm would be the ability to read a label on cleaning products, for example. It may say, if you ingest this, do X, Y, and Z. And if you're able to read that and understand it, you can protect yourself, your little ones, family members. Protection from disease, we all saw this during the pandemic, where there was a promotion to protect ourselves from COVID-19 by receiving the vaccine, masking, et cetera. There was a mass promotion of that worldwide. But amongst that information, we never really thought about, does it fit in this community? For this culture that we're specifically looking at, does the information provided make sense to them culturally? Or does it, how do we identify what's inaccurate in terms of information? Because there was so much information that was just out there all at one time. It's challenging for people to identify what's real and what's not, and it led to a lot of insecurities in terms of the healthcare system and trust in the healthcare system. Orkin and his colleagues published an article in Health Promotion International in 2022 that stated that health literacy is a social vaccine. So it's a really interesting concept to think about. That article was specific to COVID-19, but I do think that it is applicable to all communicable diseases. And then lastly, there's protection of rights. So that's very relevant current day. There's a lot of bills being put up for voting or for election and then even passed. So there's Roe versus Wade, gender affirmation surgery, et cetera. And there's a lot of literacy that comes with that. So with increased health literacy, community members are able to vote according to what they feel is best for their rights. Now, if you don't care, if you can click one more time, and a number forward, and a number will pop up here. There we go. So this is the cost. So if you don't care about anything, most of the times, cost will alarm people. So the cost of low health literacy is $236 billion a year in the US alone. And that was published by Vernon and colleagues out of the University of Connecticut in 2007. So presumably now it is higher, especially with the COVID issues that have happened and are still existing. So why does low health literacy cost so much? Starting with ER visits, the people most that use the ER the most would be age 65 and older, patients that live in the inner city, that have a diagnosis of asthma or congestive heart failure. And you have patients that are also utilizing the ER for primary care. So that's increasing the cost. It's also a burden to the healthcare system. We also have increased hospital admissions, so I touched on that a bit. The CDC has stated that with increased health literacy, we can save at least 1 million admissions a year. And then with increased medication errors, it's really challenging for patients to keep track of all their prescriptions. And with medication errors alone, it costs $94 billion a year. There's also the increased lost wages. So patients are missing work to attend, or maybe they're admitted to the hospital and they're missing work or they lose their job. Also, their family members are impacted. They have to leave work or skip work to take their family members to the hospital or take care of their family members. So it really is not just about the hospital costs, but there are other costs associated with low health literacy. So there's also increased disabilities, and one that's really difficult to quantify would be the impact on quality of life. I always think about our dialysis patients. I can't imagine, every other day going to dialysis for hours. The next day you're exhausted because you went through dialysis, and then the next day you're doing it again. So it really does impact quality of life. This is from the National Assessment of Adult Literacy. Interestingly, the government has not done a health literacy survey nationally specific to health since 2003, so hopefully there'll be another one coming out shortly. So what they did was they evaluated all adults 18 and older across the nation, and they created 4 categories: proficient, intermediate, above basic, and then basic. So I'll just briefly give examples here. For proficient would be calculate an employee's share of health insurance costs a year using a table. I myself find that to be challenging, but that's an example of proficiency. Intermediate would be you're able to calculate your BMI based on a graph that you're provided and find your height and weight, or identify 3 substances that may interact with your drugs that you take. Examples of basic would be give 2 reasons a person with no symptoms of a specific disease should be tested based on a clearly written pamphlet. And then below basic would be circle the date of a medical appointment on a hospital appointment slip. So based on these example abilities, you can see that patients really need at least basic proficiency in terms of health literacy to be able to manage their care or prevent issues from occurring. So this is the result of the survey, and this was published by Gunter and his colleagues. The y-axis shows different age categories. The x will show percentages 0 through 10 or 0 through 100. Blue signifies below basic, orange is basic, gray is intermediate, and yellow is proficient. So based on this, you'll see that age 65 and older is almost double that of the other age categories for below basic. I'll mention here that women have a higher health literacy than men. Go to the next slide, please. Okay, and this is a breakdown of race and ethnicity listed on the y-axis here. And the group with the highest health literacy would be white and Asian Pacific Islander. The group with the lowest health literacy was Hispanic, followed by Black, American Indian, Alaskan Native, and then multiracial adults. Also correlating with health literacy would be your education level. So the higher your education obtained, the higher your health literacy. So groups that would, in summary, be at most risk would be males, age 65 and older, the Hispanic population, and community members that have education at the high school level or lower. Another thing to keep in mind here is language. So this study was actually provided in English and Spanish, but despite that, it was seen that if English is not your primary language, perhaps you learned it after you started school or you don't speak it at all, you were at risk for low health literacy. So why do we care about health literacy? Morally and ethically, yes, it's important, but it's also a patient right. So there were 2 pivotal landmark cases that really changed the trajectory for our patients and rights related to health literacy. The first one took place in 1914. So in this case, Ms. Schlorndorf had consented for fibroid tumor removal, but she woke up and she found out that the surgeon had also operated on her left hand without consent. The hand also then became gangrenous, and then she had an amputation. So she sued for that, and based on that, this quote was produced. So Justice Benjamin Cardozo stated, "Every human being of adult years and sound mind has the right to determine what shall be done with his body, and a surgeon who performs an operation without his patient's consent commits an assault for which he is liable in damages." So besides the sexist language, I feel like this is pretty pivotal for 1914 because it did highlight that patients had the right for consenting any procedure performed on them. The second pivotal moment was in 1957, I believe, and this was with Salgo versus Stanford University Board of Trustees. In this case, the patient had an aortogram performed, but the surgeon did not inform the patient of the risk of paralysis, and unfortunately, he did experience that. So based on that case, that was a pivotal case because it highlighted the importance of informed consent. So currently now we live in a diverse society. I think it's a beautiful thing, but also we have to keep in mind that with a diverse society, there are also diverse languages spoken. So this is from the Affordable Care Act, Section 1557, and I've highlighted some important parts, but health literacy now needs to consider language. So we have to make sure that our patients are met with the needs to be able to understand what is being explained to them. So I guess my parents would have been a primary example where had they explained things in Japanese, they probably would have had more of an understanding of what was going on. So based on Section 1557, individuals who have limited English proficiency, so that's defined as somebody whose primary language is not English, or they have a limited ability to read, write, or speak and understand English, have the right to a qualified translator. So it cannot be a family member, it cannot be a 9-year-old sitting in the office awkwardly. It has to be a qualified translator. It also cannot be a staff member unless they are qualified. So these are some definitions here. I'll go into these definitions more in depth for the next slide, but this is the definition of health literacy by Healthy People, which is out of the Department of Health and Human Services. And they're very much evidence-based in terms of how they define health literacy. They utilize scientific evidence to create their objectives and then create their new definitions. So they revisit this every decade. 2010 and 2020 had the same definition, but there are large changes that took place for the 2030 definition. So if you compare these two, for the 2010 and 2020 definition, they state health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. 2030 really changed this, so they divided the definition into two categories. It became personal health literacy and organizational health literacy. For personal health literacy, some similarities between 2010, 2020, and 2030's definition would be that they both emphasize that patients need to be able to find, obtain, and understand health information. Some differences would be 2030 focuses on the use of information, which is important because you can have all this information and understand it, but if you can't utilize it, then it's for nothing. So 2030 does focus on the use of the information. Another change is 2010-2020 states that it's needed to make appropriate health decisions, while 2030 states that it's an emphasis on informed decision making. 2010-2020 also does not define who the decision is for, while 2030 states that it's for themselves or others, which is, it's really important to add that here because we have an aging patient population. Patients that are 65 and older has increased by 300% over the last 50 years and is projected to increase even more. So I think it's great that they added for others as well. And then the organizational health literacy part is completely new, and the focus on the presentation, for my presentation from here on, will focus on the organizational component and our responsibilities as providers. So patients do play a role, and I'll just touch on this quickly, but there are intrinsic and extrinsic factors that play a role in their health literacy. So it could be their culture, religion, support system they have, access to information, access to healthcare, access to time and money. These all play a role in health literacy. But we'll focus on the organizational part, and we'll start with micro and lead to macro level changes. So micro level changes would be us all in the room. What can we do to make a change? And I emphasize that although we're one person, if you bring all the micro changes together, we can create a macro change. So starting with creating a safe environment. You want to create an environment where patients feel comfortable with you. In the presentation, the intro presentation, they stated that the goal is to have a relationship versus a transactional encounter with patients, and I do believe that. So have a respectful tone. Also have some respect for the patient's culture. And then you want to make sure positioning is so important. We don't really think about it, but how is your position? Are you standing and they're sitting? Are you looking down where you're talking at them or to them versus conversing with them at the eye level? These are little things that you can do to create a safe space. You should also identify barriers. So these can be visual, auditory, language, and cognitive. For visual, the recommendation is to have size 14 font or larger. If you're printing material, the font print should be in black on a light piece of paper, and make sure that it's not a glossy piece of paper. Auditory, if your patient has hearing aids, utilize them. And you should also use visual aids if necessary. We talked about the language barriers that may exist, and we also have the risk of cognitive barriers that patients may experience. So this can be assessed by various techniques that I'll go through in the next couple of slides. Lastly, for you don't have to go back, it's okay. The last thing you can do is assess their baseline understanding. So what do patients know? This is a great way to empower your patients because your patients may know a wealth of knowledge, or maybe potentially they misunderstood something, or they didn't completely understand something in an accurate way. That's the perfect time for you to correct those misunderstandings. So different ways that you can provide information with health literacy in mind. Use small words, use short sentences. 5th grade level is recommended. Make sure that it's readable. Don't use complicated terminology. In COVID, remember the words like flattening the curve or transmissibility. There are a ton of medical words that were put out there, and community members are like, I have no idea what that means. So really try to avoid medical terminology and keep the words basic and use as many pictures and graphs as possible. Simplify as much as possible. So if your patients are on a ton of meds, instead of having them do at random times throughout the day, try to cluster them because it'll increase compliance. Also provide just the most important information. The example I can give here is we've all seen those pharmaceutical commercials where they give like 500 side effects at the end, and by the end you're like, I remember one, maybe am I? So don't inundate your patient with information. Just give what is absolutely necessary because you don't want to lose them in the process. Assessing for understanding is very important. So you want to ask open-ended questions. So in the end, after you provide your education, instead of saying, do you have any questions, which is yes, no, you can say, what questions do you have? That creates an environment where, yes, I expect you to have questions. I gave you a lot of information. I expect you to have questions. How can I help? The teach-back method is important. Some people feel like this could be awkward because you don't want your patients to feel like you're questioning their intellect. So what you can do is shift the focus from the patient and their health literacy to yourself. How did I do? I want to make sure that I did a good job teaching you things. Can you please tell me in your own words X, Y, and Z? So that way you're creating an environment where it's non-judgmental and you're focusing on how you provided education. And then for reinforcement, again, pictures, graphics are helpful. Highlight the important points and then involve family and support systems. Some patients may not have family. It may be somebody that's non-family, but that's their support system. They should be involved if they're directly involved in their care. So here are some examples of common medical phrases. One would be, have you had any adverse effects from the medication prescribed? This could instead be stated, tell me how you feel since starting your new medication. That changes it from a closed question to an open question, and you're eliminating some challenging words such as adverse effects. Another example would be, it's required that you take your medication twice a day. Twice a day for a patient could be 8 p.m. and 9 p.m. They don't know it could be every 12 hours. So instead you could say, take your medication every 12 hours, for example, 6 a.m. and 6 p.m., 8 a.m. and 8 p.m. An example for numeracy, instead of saying there's a 20% chance of failure for this procedure, you can say out of 10 people, this procedure will work for 8 and not work for 2. So let's move to the macro level, which is your institution. So start from the beginning. When you walk into your institution, how does it feel? Where are the signs? Are they in multiple languages? If you are in a wheelchair, are you even able to see the signs? These are little things that can make an impact in our patients. So really make sure that it's patient-centered and catering to all populations that we serve. These are a list of standardized education materials that you can utilize, many of which are free. And what they do is they assess your education material in terms of readability, the words that you're using, the reading level. Some actually even assess for cultural appropriateness. So if you have an institution that utilizes these for all educational materials across your system, it provides consistency for your patients, which is really important because remember, these patients have multiple comorbidities. They're seeing many providers across your system. So if they see the same educational materials presented with different content, it becomes easier for them to understand. Other things that can be helpful, support groups and community partnership. This provides another element of a safe space for patients, and community champions can be powerful as well. Training your clinicians is important. The goal here is to have uniformity in terms of how you're educating patients and how you're keeping health literacy in mind. And even a step back, if you incorporate health literacy into academic curriculums, then once they enter the workforce, they already have that in their pocket, and it becomes habit for them to be able to ask, for example, open-ended questions. And in terms of sustainability, policies and procedures can secure that by making sure that our efforts are continued. And then lastly, research. Our culture is always changing, so it should be assessed. We should make sure that we identify barriers that exist for our patients and in our communities, and we should implement change based on these assessments. So what I just gave you, all the information I gave you, is summarized here in our government's recommendations for the 7-step action plan to push health literacy forward. And in summary here, the goal is to continue research and disseminate evidence-based practice. You want to disseminate this information even from the child care level all the way up to university so we can reach people at different points. And obviously you'll have to adjust how you're teaching the material and what you're teaching, but it should be an ongoing process. And you should also support and build community partnerships and different efforts that are taking place at the local level up to the national and global level. So thinking into the future, we're always thinking into the future because it's always changing. So one thing to consider is digital literacy. We live in a digital world, and that could be a bane to our existence with all the social media things, but it can also work to our advantage because we can rapidly disseminate accurate information to our patients. It's interesting because even when I go to third world countries, I've done some healthcare in third world countries, and everybody has a phone, even if they don't have access to healthcare regularly. They all have smartphones. So that's a method that we can use to disseminate accurate information. But one thing to keep in mind is with that, the half-life of information has rapidly changed. So before, we would have to go to the library, find a textbook, read what's true, and that's true until the next edition comes out, which may take a couple of years. Now, on the internet, what's true at 1 o'clock may be different at 2 o'clock. So that could actually work to our advantage in terms of updating what's accurate information, but it can also be daunting. So the point here is to be able to utilize social media and the digital world that we live in to our advantage as much as possible, but also keep in mind that there can be detriments in terms of accuracy at times. I talked about the aging population and how this is increasing, so we cannot leave this population behind. We need to make sure that they still have access to all the health information. If we shift it digitally, how do we make sure that they can navigate the digital world to access the information we have? And lastly, we should diversify our providers. The patients that we're serving are becoming more and more diverse in a beautiful way, so our providers should also reflect that. So I'll finish with 2 quotes. One is by a former U.S. Surgeon General, Dr. Regina M. Benjamin, who states, "As clinicians, what we say does not matter unless our patients are able to understand the information we give them well enough to use it to make good healthcare decisions. Otherwise, we did not reach them, and that is the same as if we didn't treat them." And the last quote is one of my favorites by Dr. Maya Angelou. "We delight in the beauty of the butterfly, but rarely admit the changes it has gone through to achieve that beauty." So I left this quote here because this is an ongoing process. We all want the best for our patients. There are growing pains, but there's work to do, and the intent is always what's important, and moving forward is always important. So thank you. Questions?
So, thank you for a wonderful presentation, Mako. We're going to have our second speaker, and then we will have a panel discussion for questions, answers, and any observations. But right now, it gives me a distinct honor to introduce our second speaker, Suma Rao Gupta. I will not do her many, many credentials and her responsibilities any justice at all, but just to let you know that she is here at Lurie Children's, our Director of Patient and Family Education Services. She's an advocate. She has chaired the health literacy group here that has been very active, that I'm sure will be getting more active post-COVID. But Suma, thank you and welcome. We look forward to your contributions and presentations. So give it up for Suma, and we'll hear her words of wisdom.
Thank you, everyone, and thank you, Karen. Good afternoon. My name is Suma Rao Gupta. I'm the Director for Patient and Family Education here at Lurie Children's. I am coming up on 19 years here, so it has been a fun journey, and have had an opportunity to help shape some of our guidelines and processes that we've put in place related to health literacy. Next slide. So my objectives for today are to discuss how a health literacy task force was actually created and implemented here at Lurie Children's, and how that tied back to helping share some of these principles and learnings with our staff and clinicians. We'll also take a look at the current patient education guidelines that we have created for sort of as a support tool for all of our clinicians to be able to use, and identify some future directions where there are opportunities to support health literacy. So starting with a little bit of the basics, similar to MICO, here's a quick definition of literacy and health literacy. And of course, basic literacy skills are essential and important to supporting appropriate health literacy for an individual and how they can care for themselves and for their family members. So on the next slide, you'll see, there is another sort of layer of health literacy that we are starting to pay a little more attention to with functional healthcare literacy, as well as that self-care component. So being in a pediatric setting, I think there's a lot that we do with teaching parents and caregivers how to care for their children. So that's sort of an added layer of health literacy that comes into play when we're working with our patients and families. So why is health literacy so important? And some of this will be a little bit of an overlap with what Michael covered before me as well. But basically, the estimate is that 21 million parents, caregivers, have issues with health literacy. They have basic or below basic health literacy. So when we're dealing with complex diagnoses or new diagnoses, things that families may not have even heard of before, this becomes incredibly important to keep in mind when we think about how are we going to educate them. What is it that we need to create or share with them to be effective education for them to take home and to take care of their children. So the other sort of daunting statistic that's out there is that more than 80% of health information provided in a doctor's office is forgotten before patients get home. And that is clearly a big issue. And more than half of the recalled information is remembered incorrectly. So how can we help our families, our caregivers, have better access to information even once they leave the hospital? And with whatever we are giving them, how can we be really clear, concise, and effective to convey this important information to them? So what we're trying to do with a focus on health literacy is meet those demands, the complex health system they're navigating, the demands that the care teams might be placing on them, as well as what skills and abilities do they already have, or what do they come to the table with, and how can we help improve that or support that with health literacy as a key focus. So one of the things that I wanted to introduce you to is something that we had tried and implemented here at the hospital at Lurie Children's, and that's a health literacy task force that was brought together approximately 5 years ago with the intent that we would look at how do we make health literacy really key to all the things that we do here at the hospital. So that's relating to operations, to research, to education endeavors, and all of those aspects. So we were able to take this sort of concept and request to our senior leadership to gain their sponsorship and support to actually pursue something like this. And the original task force was co-chaired by myself, as well as one of our physician colleagues who has since retired, but she was one of our leaders in the health literacy space as well. And we tried to bring together a really multidisciplinary group of staff and clinicians, really looking at different areas. Who are all the folks that actually interact with families? How do they interact with families, and how can we help improve that and learn from them based on their own experiences? And the ultimate goal here is to become a more health literate organization, and we tried to look at some concrete steps on how we could do that. So one of the things that we looked at was, as sort of a foundational piece, was this report from the Institute of Medicine, and it talked about all these different components that went into making an organization more health literate. And one of the things that really seemed approachable, at least to start, was this environmental scan of an organization. So, and I'll get a little bit more into that in the upcoming slides. So in addition to that, we also then looked at how could we think about assessing the health literacy of patients and families that we actually see here at the hospital. And then finally, how can we think about different ways to educate our staff, our providers, our clinicians around the importance of health literacy, and also give them some practical tools to do that. So this is the environmental scan that we tried to sort of pilot and take a look at on a smaller level. This was from Rima Rudd at Harvard, and this was considered a validated questionnaire that we could have access to and utilize to look at where we may have strengths and weaknesses in the 5 different areas related to building this picture of health literacy. So those 5 areas related to navigation, technology, printed communication, actual verbal communication, as well as policies and protocols. So one of the things that pretty quickly became evident to us was that this was a very time and sort of personnel intensive endeavor. So in addition to a few staff members on our health literacy task force that offered to help, we also pulled in our administrative interns at the time to help with some of this data collection. And we had to really look at just trialing this on a small scale. So we looked at a few different clinical areas in the hospital and sort of picked certain sections of the scan to trial. And one of the things that we started to observe was that depending on who was doing this observation or data collection, there were still some questions that were a little open to interpretation. So we felt like some of the information we were collecting was still going to be a little bit different based on who was administering the survey. And then, of course, the challenges around the size of the hospital, how do you navigate actively working clinical spaces, and how do you gather that information in a timely manner. So while we did approach this, collected some initial data, and we did take a look at it at the task force level, we were not able to then take it further at that point in time due to some of these limitations. Another thing that I mentioned that we started to look at, and this was with the help of our nursing informatics team, with Karen's team, to really look at building out 3 health screening questions. And the goal of building out these questions was to be able to have a standardized set of questions that would be asked of all patients and families, regardless of where they were seen or what they were coming in for. This was, again, an attempt to build that health literacy sort of picture of what we would see with our patients and families. So the 3 questions are pretty general. They're not meant to sort of isolate any patient population or anything like that, but it was all around, how confident or able they are to fill out information, read and understand information, as well as clearly understand written content that was given to them as part of their care. So when we also tried to quantify this with a scaling of 1 to 5, and anything that would be under 9 would end up being deemed as low health literacy. So to help our nurses with asking these questions, we did come up with some scripting, and that was, again, meant to help our nurses who were asking these questions feel comfortable and also put the family at ease when they ask these questions. And then on the right side of the screen is a screenshot of what some of the education went out to our nursing staff, with providing that context around health literacy and why we're adding these questions and why it's something meaningful that we're trying to put in place. So probably one of the most common questions we got was, okay, once I ask these questions to a family, what needs to happen next? And so this was a real opportunity for us to try to share more information around using plain language, around the guidelines and the guidelines for patient education that we were putting in place, and incorporate those concepts of teach back and how you can use plain language and encourage a conversation and open questions with patients and families. In addition to the environmental scan and the health literacy assessment questions, we also looked at what could be ways that we can share this information with our staff, our providers, across the organization. So one of the things that we had a nursing student, for example, who did a series of mini in-services on her unit to familiarize her peers with what health literacy was all about. What were some practical tips and things that they could utilize when they were working with patients and families, and that was really well received. We created an education module for our mandatory education that gets rolled out, which is not always the most popular approach, but it's a way to reach a lot of people with a core set of information. So that was another thing that we had rolled out a few years ago. And towards the end of 2019 into 2020, we looked at actually having a small grant, a seed grant, to help us with rolling out sort of a broader approach to multidisciplinary education and incorporating teach back and some of the practical tools that we could then take to both nurses and residents and look at different clinical areas. But those efforts were interrupted with all the disruption with COVID, and that is something that we still plan to and want to get back to. And then the last thing that I'll highlight as something that we also did with our core health literacy task force members, and this picture includes Vera, who's here in the room with us. We tried to organize some events and fun sort of ways to engage our clinical teams and different staff across the hospital during the month of October, which is generally Health Literacy Month. And so, this included an information table, lots of messaging on a daily and weekly basis. And then we also built in some sort of Q&A and raffle prizes over a couple years during the month of October, which really helped us to at least start getting this information out on a broader scale. And then one of the other things that we've really done for quite some time now, and most recently within the last few years, we've revised these and updated these, is trying to put together guidelines that our clinicians can use when they're actually looking to create a lot of custom patient education content, which we do a lot of here, being a specialty pediatric hospital. This is sort of the overarching theme that is important here with health literacy, right? If you look at the individual on the left side who is, in a provider or clinician role, and the individual on the right side is that parent or caregiver or the patient, what you don't want happening is what you see in the image on the left, right? The provider giving information and the patient is really not understanding or following what's happening. Our goal is really what you see on the right side of the screen, so that it's sort of this one-to-one, it's clear communication, you're actually getting information across in a way that's understandable and can be received. So I had a little video snippet here. I'm not sure, should I just try it? I'm hoping it'll play on Teams.
It will.
Okay.
Excuse me, sir. I'm so sorry. She's been crying nonstop. She has a temperature of 105. I don't know what to do.
Vi horrores sant.
Please, just every time I see her, she throws up. I don't
Vi horores
understand what you're
sant.
saying. What are you saying?
Can
Can you just look at her? No, she's burning up. Just keep.
Vi horores la anglan.
What? She's burning up. Feel her head.
Tranquilly, Kanache. The mother is Askan.
What is he doing? What's
Do you have?
my baby? She's got a temperature of 105. Every time I feed her, she throws up. Please, can you?
Tienes que ir a Porton Torasco.
She's burning up. Feel her head.
Paramedic.
Please, just feel her head. Feel her head. Just someone let me in to see the doctor. Does anyone understand what I'm saying? Please, someone help me.
8% of U.S. citizens speak limited English. For these 25 million Americans, professional interpreters can mean the difference between life and death.
Sorry about that, Sue.
That's okay. Thank you. So if you go to the next slide, that video was really just meant to help put you in someone else's shoes, right? What if you were the one with an infant who is incredibly ill and nobody can understand you? What would you do? How would you feel? And that's really what the intent of showing you that video was about. So with all of those things in mind, at the hospital here, we have a patient family education team, which I'm a part of, to help work with our clinicians in order to create a lot of these patient education content and resources that we're then able to share with our families. So one of the first things we say is reach out to us when you have any kind of a request where you're trying to create content. On the next slide, we kind of highlight a little bit around what those objectives are, what you want to think about if you're approaching a new topic, a new project, identifying a new need that you're trying to meet. So identifying your audience is one of the first things that you want to do, regardless of what the topic is. So if you're talking to parents of an infant, what you're putting together is going to look and sound different. If you're talking to a parent of a young child or a teenager, that's different. If you're talking directly to a teenager, that's going to look and sound different. So identifying your audience and all those sort of nuances that go along with it will actually really help you define your objectives and then what your key topics are that you want to address when you're creating this content. And this applies to whether you're creating written materials, which we still do a lot of, or if you're creating a video, which we're starting to do more and more of on different topics. So next slide. So what you want to think about as you look at your audience is, what do they already know and what do they need to know that might be new or different, and what is it that you want them to actually walk away with that is sort of actionable? What is it that you want them to be able to do once you share this information with them? So again, defining those objectives and what the outcome is for each of those objectives will really help you shape your content. And this illustration is an adaptation that, again, my colleague Vera had helped adapt, is to look at, what is it ultimately that you're trying to impact, which is all the way on the right side of the illustration, and that's to improve their quality of life. So starting from the left, you look at the things you can impact, starting with that set of knowledge and skills, which is what you're directly impacting with the education you're creating, and then going over along each of these with increasing their self-efficacy, chances that they're going to stick to a medication regimen or therapy, and ultimately improving their quality of life. Some other important considerations, like we saw in the video, language barriers. That's a huge issue for any larger organization that has varied patient populations as well as medical diagnoses that they're dealing with. Anything you can do to provide cultural sensitivity, and then of course with health literacy, one of the biggest things that we're going to look at next is using plain language. So using plain language is exactly how it sounds. Use simple words and phrases, keep them short, keep them brief, avoid a lot of complex sentences, avoid jargon. That's incredibly important. I think being in a medical environment, we're so used to doing that with each other that we sometimes forget when we're talking to patients, families, and caregivers. Really try to minimize abbreviations. Make sure you're defining your terminology and use consistent terms. That's something that also we see variation with when you go from one clinical area to another. Different people use different terminology. So if we can be as consistent as possible, that's really going to help. Numeracy is another thing that is becoming more and more important, but we have to be really clear and specific. It's not just enough to use numbers. You want to actually still explain what it is that the numbers mean. So the illustration on the right gives you a little example of that, where taking 2 pills a day for 2 pills 4 times a day can mean a lot of different things. So actually spell it out, specify, and then your patients and families are going to be much more clear about what you're sharing. So when you're looking at writing, these concepts, you want to think about the context that you're sharing with the family, sort of a brief introduction, if you will, and then the action of what they need to do, and then if there's any kind of follow-up to the end of that action, then you can include that at the end. So the sentence at the bottom of the screen is an example of how you could piece those things together. On the right side of your screen is another example of how you can put plain language into action. So the text that's in the red is sort of the original sentence, which is very common to things you might see, as part of guidelines or on websites. And then what you see in green, really much simpler, shorter, to the point, but it's sharing the exact same information. Something else you want to keep in mind as you pull materials together or a draft of your content is, making sure you have a key message, because a lot of things that you might teach families about can be quite broad. You may have a lot of information that you're actually looking to share, but we want to organize it so that it makes sense. A lot of times clinical teams will want like one comprehensive, large booklet to give a family with a new diagnosis. And if that's their approach because they want to continually refer to it and use it, that's okay, but we still want to make sure that with each chapter or with each section, or if it's a single handout, you want to make sure your key message is clear. You want to make sure that you're chunking your content so that it's logical, it really flows in an orderly manner. And you want to use bulleted lists or like a sequence of steps whenever it's appropriate, so that it's clear to the reader that they have to actually follow it in that sequence. Another thing you want to keep in mind is, the font size, that it's large enough to read. It's usually like a minimum of a 12 size font, as well as leaving white space. A lot of folks get stuck on, I just need it to be a one-page handout. No one's going to look at it otherwise. But if that one-page handout is incredibly crowded and dense with information, they're not going to read it anyway. So you're better off with incorporating white space, making sure if visuals are appropriate and help explain your concepts, not visuals for the sake of visuals, but actually meaningful to your content. You want to incorporate those, and then label anything, with captions or with illustrations. Sometimes you may need to obtain permission. So those are some of the other things to keep in mind. And there's many different tools out there for assessment. I'm just mentioning one of them specific to patient education materials called PMAT. It is a little more intensive to use, but it's something that I just wanted to mention because it is seen as sort of a reliable tool. And when you're working within Microsoft Word, one of the easiest tools you have access to is Flesh Kincaid, which is sort of built in now to Microsoft Word if you just want to sort of ballpark where your document lands in terms of reading level. So how can we improve patients' families' health literacy? This is, again, looking at Teach Back as a key component of how you communicate with families and making sure that you can get their input on how you've explained things to them, and really looking at it as saving time for you on the tail end of things. It may take a little more time on the front end, but it's actually going to help your patients and families. It's going to help you. It's going to help the process overall. Another tool that had gotten some attention a few years ago that I like how it's broken down is called Ask Me 3. And Ask Me 3 was meant to be an educational program to help break down concepts and explain information to families. And this is another, it ties into Teach Back, and I think it's another nice way that you can sort of flip these questions around to then create that conversation with families and help them ask the questions that you want them to ask. And then last but not least, certified interpreters. That is so key to being able to provide necessary language assistance to our patients and families. We are fortunate to have a great team of certified interpreters and translators here at the hospital. We also have video interpretation support for a lot of other languages that we may not have presence for in-house. So that is definitely a team that we engage with quite a bit. And then this is just a little checklist that I like to refer people to so that you have some sort of a framework as to what to think about. And for folks who are used to creating education content, this may not be new, but this is a really nice tool for people to use and think about when they're newer to the process. And then I'll wrap up with future directions. This is something that I recently came across probably within the last year or two, and it's a health literacy specialist certificate from the IHA, which is the Institute for Healthcare Advancement. And their goal with rolling this out is to really look at how can we make health literacy much more accessible and sort of elevate the importance of it to achieve health equity. And I'm sure health equity is sort of a term that you're hearing more and more of in a lot of different care settings. And this is, I think, in my opinion, is a great tool for multidisciplinary team members. It really focuses on how you can improve health literacy. And it's got 7 kind of key components that it's broken down into, which are listed on the right side of your screen. So you can see it tries to approach it from a lot of different perspectives, and that's something that I really appreciate for our type of healthcare setting, where I think a lot of these things may not be top of mind, but this type of a program really introduces you to those concepts. And this is something that we're actually incorporating into our patient education team, and I have a team member right now who is going through this certificate program. And then I also wanted to give you a resource that I have found incredibly helpful in my time here, and that's the Healthcare Education Association, called HCEA. And it's a group of multidisciplinary clinicians and other educators who come from mostly healthcare organizations, but also other organizations. And the whole goal is to improve how we provide health education, but then also making sure that it's evidence-based, and we have a professional network to sort of bounce ideas off of each other and actually communicate and present our projects and findings at conferences. So this guideline is something that they recently came out with, formalized. It took years of work, but patient education practice guidelines, and that's something that I'm hoping in the next couple years that we'll be able to also share here at Lurie Children's in sort of a broader way. And I think moving forward, I see sort of this growing need for consistent support and consultation related to health literacy really across programmatic areas. It's not just clinical instructions anymore. It's not just patient education, but really as an organization, what is that face that we're putting forward, and how can we make all these different aspects of it more health literate? So one example I like to share is with our research teams in the last few years, they had put work into improving, modifying their consent forms, for example, making them more understandable, more accessible, and that really can have an impact on your clinical trial enrollment. So really meaningful, practical ways that you can start to chip off pieces that are going to become more and more important. And another movement you see is with like medical records and HIM. How can we ensure, as more and more information is released into your personal medical records, especially electronic medical records, right? How can we ensure that families are understanding what information is being released? Yes, it's your information, but do you know what it means? And are there things you should know that are not going to be clear right off the bat? So I think that's definitely another growing area that we're going to see more with. So that's the conclusion to my presentation. I have some resources and references in the appendix, but here's my contact information. If you are here at Lurie Children's, please reach out. Even if you're elsewhere and you want to get in touch, I would be happy to stay connected. So thank you for your attention. Yes.
So, thank you both for such an informative lecture today. I was wondering what the status of, it sounds like you guys tried some pilots of doing these questionnaires, mapping, but they were time consuming. Like, what is the current state of that right now?
So current state is...
So please, I think I'd like to have you
repeat the question.
Repeat the question,
sure.
So that everybody can hear what Sue is asking about, please.
Sure. So the question was around with the Health Literacy Task Force and some of the initiatives that we had started to pilot, what is the current state of it, and where would we go with it in the future? So I would have to say that it was two things that sort of happened at the same time. One was COVID, and the other was my co-chair physician who retired. And so one of the things that we tried to do in this last year was recruit for new co-chairs, which there's been a lot of interest, but I think the practical standpoint of people's time has been a real barrier to revamping it in a meaningful way. I think we had one meeting, but beyond that, we're really needing to be able to have people have protected time, if you will, to be able to meaningfully contribute to it. So in the next year, my hope is that we can revisit that and see what can we chew off that is practical, but continue the work and continue the work of the task force, because I do think that really helped raise awareness, and it helped pull in folks that may not have otherwise, come to the table. So.
Yeah, no, that's very helpful, because I know it can be time consuming, but I work with many families that putting that time in the front end can really save a lot of time for staff, and also, better outcomes for the patient.
Yes.
And families. So, yeah, having that access, there's a family that has numerical, literacy that really could use some tools.
Yeah.
Yeah.
Okay. Thanks.
Any other questions? I think somebody's typing online, but we do have the opportunity to ask questions. Okay, so, can't read it from back here. So, working in DBP, there are so many topics to address with parents for their children with autism or developmental delay. What recommendations do you have to keep education focused when there are so many priorities to address? So great question.
I think with mental health, especially in pediatrics, that is such a growing need. And that's something that we haven't necessarily spent, I think, as much dedicated time on. I do know there are some new tools and resources from other pediatric organizations as well as mental health organizations that have started to come out. So I think, as an organization, that's something that we can definitely set up some time to, look at, to review, to examine if those would help meet some of those needs. And I think it's a real opportunity for us to be able to then create, if we don't already have, or adapt what we do have to address some of the new needs that our requester shared with what she sees with patients and families.
I'll just add another thing, which is within healthcare systems, we have to be time conscious with the amount of time we have per patient, and that's the reality of healthcare here. So we should take advantage of being able to educate patients outside of the system. So the goal could be they're provided information beforehand, and when they present, they can come with questions, and it's a better utilization of time. And also an opportunity for patients and their family members, their caretakers, to come in with their own priority list of what they have questions on or what they'd like to focus on for that appointment.
Thank you for that very complete answer. I don't think there's a recipe, but you certainly focused in on some of the important points in terms of priorities, having information sent when you can beforehand. And I think that also, just to put a plug in for Suma's health literacy group, I think that that would be a potential avenue for addressing more in depth as we hopefully progress as an organization in doing that environmental scan that you talked about, and what do we have available, what can we do better?
Absolutely. Yeah.
Hi, has there been any
Yeah.
has there been any consideration of sort of pairing or rolling health literacy under Dr. Wheeler's high reliability organization? Because it seems like there's a fit, but I've not.
Yeah. So the question was, at Lurie Children's, we have this broad multi-year initiative around becoming a high reliability organization, and that touches a lot of different aspects of our clinical care that we provide. So, is there an opportunity to tie health literacy into some of that work? And I think there is. I do think some of the work that was starting to get rolled out around how to interact with families and how to encourage them to bring up questions about their child's care. There was a little bit of a start and stop with some of that work that happened, but I do believe it did roll out more to the clinical units. And there is definitely a health literacy component to that we were providing some input with, and that we were looking to expand on as we move forward. So that's sort of like the first immediate example that comes to my mind, but absolutely, I think there's a lot more opportunity to partner on those high reliability initiatives and, really help shape some of that language and how it's shared.
I have a question about the use of interpreters.
Mm-hmm.
So there are two things. One of the things I find as a clinician is that when I'm using an interpreter, it's much more difficult to gauge the family's understanding of the material that I'm presenting to them. And I was wondering if you have any suggestions about how to improve that. And then the second piece is that I had recently read, and I can't remember where, that when you use an interpreter, basically like positive talk goes down. Like basically that kind of positive chit-chat talk that you have with a family is reduced when you're speaking through an interpreter. And so now that I know that, I'm more mindful of it. But is there any ways that you would suggest to increase positive talk when you're using an interpreter, and better ways to gauge understanding?
Okay. So the first question was.
We should pass that.
So one of the questions, you had a two-part question, but one of them, I'm going to start with your second one, but was how do we increase the sort of the informal talk and how that allows for more connection with families when you're using interpreters. And I think I agree, that's a really difficult one, because I think when you're working with the interpreters, you're probably, things are time-bound again, like you just referenced, right? But I think maybe having that conversation with the interpreter, maybe before you even start the interpretation, or perhaps ask them for some suggestions on how to incorporate some of that small talk back into the conversation to help put the family more at ease. I think our team of interpreters would definitely be open to that. And they are always looking for ways to sort of better partner with the clinical teams and to help the process. So I think that would be a great point to bring up to them.
I think there's also nonverbal communication and connections that you can make with patients. When you walk in, making eye contact, being at eye level, these are just small things. I like to sit next to the patient instead of standing over, especially Audrey and I both are nurse anesthetists, and oftentimes our patients are laying in the bed. So it's easy to just stand and speak to them versus finding a chair. Sometimes it's a trash can or whatever it may be, and you sit and you can make a connection with them non-verbally by just opening and clearing the environment to be respectful and open. And in terms of, I think your second question was asking how do you assure that your patient understands the educational material. I think the teach-back method can still be applied here, where you do utilize the interpreter, but you can still say, what questions do you have? And there's going to be several steps that come because there's an interpreter, but hopefully it still provides this similar, if not same, opportunity for patients to be able to ensure that they understand the education provided.
We're here from the Department of Psychiatry, and I know that Suma, you've helped review some things in the last year or so for our one of our committees. So thank you.
Of course.
But I guess one thing I wonder is, we have some forms in our department that have been used for a long time. Maybe they've had small edits, but how do we know if things have been reviewed for health literacy? Like, is there a certain sign-off that would be on them if they had been reviewed by your group?
Yes, so we've been able to, over the years, sort of formalize the process more. So I would say let's connect outside of here today and make sure that what you're looking at are things that have come through my team, and if not, then we can revisit that. But generally speaking, we have a template for patient education materials, which is now sort of branded as patient education. We usually have a disclaimer at the end of our handouts that sort of say, make sure you're still talking to your clinical team, to your provider. This is not meant to just be a standalone set of guidance, but you should use it with your care team. And then there's also usually a date on the bottom of either when it was reviewed or created. So those are some of the sort of stamps that we've created over time to make sure that it is seen as an official patient education document.
Okay. Thank you.
Sure.
It makes me think that we have probably a lot of things to be reviewed.
Yeah, happy to work with you.
For those who are online, please feel free to either ask a question or to type in chat, and we'll read it out loud while we have access to Maiko and Suma. I know that we've gone over, but I learned an incredible amount. I was struck by the concrete evidence-based suggestions you both have, and I know in my role I will be very conscious to take those into consideration, so thank you. And I do see somebody's typing, they're saying thank you. Please note that this presentation will be on the JBI site, and we just are very appreciative of both of your expertise. So once again, just thank you to both of our